Hello, Overcomers, and welcome to this episode of Connect Over Coffee. I'm Runsi, the founder of Overcome, and today we are joined by a very special guest, Dr. Premal Thaker. So Dr. Thaker is the Director of Gynecologic Oncology Clinical Research and Chief of the Division of Gynecologic Oncology and Distinguished Professorship at Siteman Cancer Center. Dr. Thaker cares for patients diagnosed with gynecologic cancers through treatment and recovery. She is consistently recognized in the Best Doctors in America list, with many areas of expertise and accolades. However, her passion for our overcomers shines the brightest. We have a lot to chat with Dr. Thaker today, focusing on a deeper understanding of clinical trials, low-grade serous ovarian cancer, as well as general advances happening in the ovarian cancer space. So grab your favorite beverage. I have mine, and let's connect over coffee with Dr. Thaker. And if you have any questions as we go along, please type in the comment sections below, and we'll try to get it addressed post the discussion. So with that, a huge welcome to you, Dr. Thaker, to this episode of Connect Over Coffee. An honor to have you with us.
Thank you so much for that kind introduction. I'm very honored to be here and be part of this podcast.
Thank you. So, we hear the word clinical trials a lot, and but before we get to the details of it, tell me what or who is a clinical trialist, and what motivated you to get into clinical trials, and what should our overcomers know about what should get them motivated also to learn more and sign up for clinical trials?
Well, that's a huge question. So clinical trials are really, I think, the backbone of medicine, because everything we actually considered as standard of care today for treatments, we're really on a trial. I sort of tell everyone that, it's not like we're so special that we know that this is the magic to give in terms of chemotherapy or what order in terms of surgery until we actually do clinical trials. So clinical trials are just really to try to figure out best practice of medicine and hopefully make it a new standard of care. So I think the reason that most people become a clinical trialist is because they really have a passion to advance the science and the state of art for the treatment of patients. Because we know we do okay, but we obviously want to do better and continue to do better. And that only comes with scientific sort of discovery and inquiry and being inquisitive. And I think that's really what drives the clinical trialists, because just like we have successes, sadly, we do also have trials that don't pan out as we think. But we learn from them and hopefully improve. And I think clinical trialists are typically at larger academic centers, but there are larger community centers, even smaller community centers that can provide clinical trials because there's so much a variety. When we think of it, we always talk about the ones that hit the news that are always this is the newest and greatest drugs. But there's even like trials on interventions for like exercise and stress management and healthy diets. And so there's so many different ways that people can actually engage in a clinical trial. So I think there's a clinical trial for every patient, as long as they're inquisitive and want to know about what they can do.
Thank you. So what is unique about clinical trials in gynecologic oncology, and what gaps have you seen when it comes to the overall knowledge and interest level in clinical trials? And how would you improve the accessibility of clinical trials for our overcomers, not just locally, nationally, but globally?
Right. So that's a great question, because the fact is really the FDA has also realized that we don't do as well in terms of having actually adult participation in clinical trials. So adult participation of cancer patients only ranges about 3 to 5% of all patients. So very low, unlike our pediatric sort of counterparts who do much better, where it's sometimes as high as almost 50% or even higher. Which is really interesting to me, because I feel like as a parent or as, somebody who has children in their life, you're probably more protective of children. But, I think in some ways you just want that extra hope that you really are a little bit more adventurous in that sense. So I do encourage people to go on and look at clinical trials, because there's a variety of trials and phases, which I failed to mention. So a phase 1 trial is much more experimental, like trying to see if this drug is safe in human beings. Is it really also effective, hitting a target? A phase 2 is like, oh, we figured out it works in gynecologic cancers. Maybe we should put it in that space. And then a phase 3 is really trying to be the next standard of care. So I do think, based on the phase, there's definitely less of a risk for a patient if they're sort of a little bit more hesitant, because they will get standard of care versus something maybe standard of care plus is what I like to say. But you have to accept you're going to be randomized, which I think sometimes as adults we're like, I don't know if I wanted to chance that, am I going to get this treatment or not? But in the end, you're going to get at least the standard, if not better. So it does give you that opportunity to help also give back. I think women especially are very excited to help. That's a part of a characteristic of a woman, right? Nurturing, taking care of others, and sort of maybe making the better treatments for our sisterhood, our womanhood, our patients of the future. That being said, I think gynecologic oncology has always been a smaller portion of clinical trials, but that's changing because now we're in the era of molecular testing. And because of that, a lot of trials are becoming more what we call tumor agnostic, meaning that they're being driven by the cancer biology and not like, oh, it started in my ovary or my peritoneum. They're really looking at signatures. So I think that's helping, make a lot of pharmaceutical companies and even science just more passionate, because you feel like you have a larger audience than just a disease site. But I do think we still find that there's underfunding for gynecologic oncology and just female cancers in general. We do unfortunately still see gender gaps in addition to ethnic gaps. Even in the United States or even worldwide, we're trying to have these trials be very international. So having our Asian colleagues, South American colleagues, Indian colleagues, everyone join in, because we do also are starting to appreciate the differences in how we all metabolize drugs a little bit differently based on where our ethnicity may have originated from, because that's also a word that's getting very melted, right? There's lots of very various sort of, it's hard to even designate people as one ethnicity or race anymore. So it's interesting that we're trying to overcome that. And I think I give kudos to a lot of the pharmaceutical companies realizing that, because sometimes there's definitely different needs in different countries of how to even perform a clinical trial. In the United States, we have the FDA who helps us. In Europe, it's the European EMA who does that. And then in India, it's a different, so it's sometimes really hard for, companies to even overcome those barriers. So it's nice to find clinical trialists who are champions, because I tell people clinical trials are a labor of love, because they're more intense for the patient as well as for the physician. So, it's one of those things that you have to be really passionate about. Both because you want to encourage patients to really try to get the best care, but understanding that that's what our hope is, but sometimes we're not always correct. So it's that moderated sort of optimism, I would say.
Thank you. I have two follow-up questions on that brilliant answer. So you said that, 3 to 5% adoption rate for clinical trials. And is that across all types of cancers, or is it just gynecologic cancers?
No, it's all types. So that's what's really a push, because a lot of places, a lot of patients don't get their care in the community. So one of the hats I actually wear is I partner with the Association of Community Cancer Centers, because I've always been sort of privileged. I worked at, I did my fellowship at MD Anderson. I was at Penn as a resident, and then I came to Washington University, where it's a big center. It's a national comprehensive cancer center. And we're very fortunate and have all these resources. But even though I sit in this area and I get to see women all the time, I realize there's a lot more women who are being treated in their communities and getting great treatment, but maybe not having the same access, right? So how do we educate, even when we do get some of these newer and novel drugs, that, a medical oncologist may only see 1 or 2 ovarian cancer patients a year, because they really are seeing lung and GI and breast. And so they're not as focused on our ovarian cancer patients. So how do we get that knowledge out? So that's the other thing, is not only do we want patients to participate, but how do we educate and disseminate that information? Because some patients are very savvy and go on like groups from yours where they can get lots of information. Then there's some patients who don't. They just rely on whatever their physician tells them. So we have, we need to have a multi faceted attack of how do we sort of get every woman to get the best care possible wherever they may be. So, globally, I partner with a group in India, for instance, who does sort of, medical second opinions, in order to get advice of, are they getting the right treatment, especially when they have a recurrence? Because I think that's where it gets a little more tricky, when it's upfront, our sort of therapy is a little more standardized. But then in the recurrent setting, it gets really sort of interesting. What should you do? How long have they been disease-free? What is their molecular characteristics? What trials might be eligible? Because some patients are even willing to travel or have the means, and others don't. I think that's one of the things that clinical trials also is helpful, because some of the pharmaceutical companies have realized that there's lots of patients interested, but sometimes there are social determinants we need to overcome. Gas cards, hotel and lodging, because they may be coming from such a distance that they need that extra support.
Yeah.
And I wish I could provide, and all of us wish we had endless buckets of money, as fundraise all the time to help provide. So we're trying to get those type of supports to get people access if they're interested. And so I think that's also critical to sort of lessening those gaps, so we get a better idea about treatments that will work better.
Yeah, and I think you may know that our Overcare program directly addresses all these needs to close the gaps. So that's very important what you said. The other thing that I was going to ask you is about, you mentioned 3 phases of the clinical trials, right? So the phase 1 being more experimental, phase 3 is being more closer to market kind of a thing, for a lack of better word. So when patients are, kind of looking into their options, like from your experience, what have you seen the adoption rates between the phase 1 versus the phase 3? But to me, what seems like most patients would be a little more comfortable signing up with phase 3 versus a phase 1, which could go either direction. But what do you see from your experience?
So I would say that I think you're exactly correct. Everyone would rather have phase 3 because it's a little bit more of a sure thing, right? But, once you've also suffered a recurrence, a couple of times, sometimes it becomes harder to find or have faith that the sort of regular chemotherapy or, agents that you've been on are going to work. And so what I tell patients are, yes, a phase 1 and phase 2 sounds scary, but if we have a good biological reason of why, and you're willing to hear the side effects and, understand also the benefit of a clinical trial is that you get much closer monitoring. And so that means more CT scans, and sometimes, as I said, more visits on a patient's part too. And I don't take that lightly, but it's also to ensure safety. So if something is not working for you or you're having a side effect, then you are more likely to get off of something that's not being effective. Where, as standard of care, we sort of are like, let's try 3-4 cycles and then we can image you again and see. But here, sometimes we're imaging every 2 months to try to see, are you having some benefit or stabilization of disease? So I do think it is always a little bit challenging. And I think if somebody has participated in a clinical trial and they've had a good result, then they're more apt to have that faith to go into a phase 2 or phase 1. And that's where, patient advocates are huge. Having someone who's gone through what you're going through, being in your shoes, and then talking to you about it. Because there's the buy-in from the physician, but also just having that sort of person support you through. And I've done that with patients because, sometimes we have very young patients who feel like, I must be the only person who's ever had this happen to me. And then just having another friendly voice on the other end, or someone who even volunteers to come to appointments or tells them their experience, has been super helpful. So I think, it's a team approach. There's patient navigators that sometimes help because, we talked about some of the financial stuff, but then there can be language barriers depending where you live, especially in a global areas that you're looking at. There's different dialects. And just because, I think of Hindi as just one example, right? In India, someone speaks Hindi, but they're like, no, my dialect is a little different, or I speak, Gujarati only, I don't speak Hindi. So trying to get that comfort and looking at a patient and their family and trying to also have the time. Because I think what also happens is it's a lot of time in educating a patient. and their family. And sometimes it's multiple visits. It's not as easy as saying, oh, here we are, sign on the dotted line. It's letting them digest the information, because it's overwhelming when you're talking about cancer, whether you're just newly diagnosed or it's come back, and trying to really get them to be accepting of what they're hearing, because it's hard to hear all of this, right? We all filter and probably process a percentage only of what's said. So giving it according to the patient and their needs. Some patients are like diving in immediately, and some need just a little bit of a slower pace, or just need to bring another set of ears. So I think that's having the time, which is also important, because if most of us look at our medical appointments, they're rather short. And so we need like our nurses to help, as well as patient navigators, like I mentioned, and others to help. So to make a comprehensive team for that patient.
Makes sense. Thank you. So, in terms of making a clinical trial a success, you talked about a little bit earlier about the failures that may happen.
Mhm.
So, but to make a clinical trial a success story, what resources are critical, and what lessons have you learned from running clinical trials that did not meet its endpoint that you have then applied to the success of your current or future trials?
Yeah, so I think, in ovarian cancer, we've been very fortunate. We've had some really huge successes. I mean, I remember seeing the presentations of the PARP inhibitors with olaparib maintenance and niraparib maintenance, and people just like almost crying, because we were like so amazed by seeing the hazard ratios, which are really showing the decrease and prevention of cancer coming back. That we realized, we are making huge differences. And so I think the key to those successes, and I use that as an example, because if you go back to the PARP inhibitor story, we're talking about 2019 as this huge success, but in 2011, the company didn't even think they might even pursue a PARP inhibitor, because they had seen like very limited success. And that's also the problem for all the sort of great success stories we do have a lot of drugs that don't make it there. And so sometimes it's persistence and believing and knowing the right population. So I think that's what we're improving, that we write these trials, broadly enough to be, helping a lot of patients, but also hopefully picking the right population so it can work, because sometimes with the all comers, it's not going to work in everybody. And do we pick the right patient population? They have the right molecular signature, or they have had only one or two recurrences. Because I have lots of patients in ovarian cancer who are like, I can't believe they won't let me on this trial because I've already had two recurrences. So we do have some trials that we allow 3 or 4, maybe more, but really trying to sort of position it in the right space, because I think we've learned that if we allow too many people, then sometimes we dilute maybe the effect and may not allow a drug to proceed that could be really beneficial for patients. And I do think you see that in the breakthrough designations, because I've not seen it in a TRK fusion yet in my practice, is because it's only like 1% of patients. But for that 1% or that one person, that drug, which is approved, is huge. It's going to change their outcome. So I think we're really in a space where we're like personalized medicine and precision medicine is more than just a statement. It's a reality. And that's where these trials are very helpful. Like even if it's a phase 1, if you have the target, then it could be very successful for you, even though maybe only 40 patients go on that drug. So it's really trying to keep yourself apprised of it. The good thing is patients have access by looking at, in at least the United States, for nciclinicaltrials.gov, because it tells you how far a radius are you willing to travel even. So patients have an ability to even search things out. I mean, I've had patients send me things and say, I hear your center has this trial open. Am I eligible? And then they come and seek us out even from, different parts of the country here in the US. So, the world is small in some ways as well because of the internet and connections, but it still has a long way to go too.
Wonderful. And so I was reading up about your research interests, right? So it's cited that biobehavioral influences on cancer development and therapy in gynecologic malignancies is your area of research interest. So tell us more about this and some of the clinical trials that you're running, and how may our overcomers sign up if they're interested?
Yeah. So, for me, you hear my passion for drug drug development. But I do have, I'm a first generation Indian American, and I still have a lot of Eastern influences, and I definitely know that there is, a lot more to be said about sort of just our whole general health in terms of, stress and how do we sort of how we feel stress, right? Because I tell everyone like what stresses me may not stress you or might not stress somebody else. And so it's a very independent sort of, definition of what it is, right? Like if I'm not doing 5 things, I'm like, oh, I must not be doing it right. And my husband's like, I'm doing one thing, I'm doing it well. So I'm like, everyone's different.
Yeah.
And I use that, but I did see that, like, there are patients who will, just from my clinical observations, they're very highly stressed or depressed or, feeling really low. And then, they can still have the same surgery, meaning they have an optimal debulking, but yet their outcome is very different. And so trying to understand that and understand the biology. So for 10 years, I had an RO1, which was collaborative, which I know you had Dr. Sood on from MD Anderson, who's one of my collaborators because I was in his lab. And we really wanted to sort of look at the biology because everyone has always looked at it from just a survey and not understanding what are the downstream effects. And so we developed preclinical models and we were able to really demonstrate that there's a difference in the tumor microenvironment. And that's really what it lets the cancer to be more permissive to continue to grow or attack. And we found, a simple thing as a beta blocker can be helpful. So we've done a couple of trials looking at beta blockers in conjunction with standard chemotherapy and have seen good benefits. We're also seeing much more data about stress and our immune system and how it sort of depresses our ability to fight cancer as well. So we're seeing an emergence of this. So my hope is, just like I said, there's a targeted therapy for you that we will give you like a prescription of for you saying maybe yoga, mindfulness, or whatever medications that will also help in addition to your standard therapies. And so we're trying to actually initiate a center like that here in St. Louis. And we're just in the beginning. We don't have it open, but we're hoping to develop something that's much more than just saying, take your chemo and your surgery, but how do we prehabilitate patients, whether it be, exercise, nutrition, mindfulness, psychological. So really trying to do more of a comprehensive approach and seeing what our outcomes are. And right now, what we do have open is something done with one of my other collaborators called the Living Well. And it's actually something that you can Google online, and it's done through University of Iowa. It's for survivors or people who've only had one recurrence. And they actually get randomized to either a psychology run Zoom therapy, and they talk about like mindfulness, like we talk about, or, coping and stress reduction versus standard of care, which is more what the NCI and American Cancer Society says, which is like sleep and nutrition and all of that, to try to see if we can really over time longitudinally see a decrease in these patients' sort of, depression, anxiety, their stress levels, because there's lots of great surveys to sort of show that, because if we do, then maybe we'll also change the recurrences. So we're just in the infancy of a lot of this sort of type of, watching and waiting. Because I remember when I first proposed these things, people are like, that's more psychological interventions. That's not biological. And I'm like, no, it's all connected. The mind is the most powerful part of our body. And so we just need to realize, how do we change that to help us, right? Because we're all every day faced with such stressful things. But some patients get cancer, some don't. And how can we change their outcomes? So I think it's really exciting. And I'm also excited to see that there's so many different cancer biologists now starting to be interested in it, because before, when I started proposing this now, I hate to say 15, 20 years ago with Dr. Sood, we both were like, people were like, that, you don't need that. You don't want that. And I'm like, yes, we do. We need to learn. So we're starting to do that.
And so this Living Well is led by Dr. Lutgendorf, right?
It is.
She actually spoke at our Zeal for Teal Empowerment Series event this year. So she spoke about exactly this study and what the stress, and she has been a collaborator with Dr. Sud as well. So very familiar
Right.
with that study. And she has actually, we are helping her recruit patients as well for her study. So
Which
very
is wonderful.
yeah, yes, exactly. And this is such an important, and I'm so happy and so glad that you're bringing up these points because, the science and the clinical aspect of cancer is, of course, it's important. We need new drugs, new advancements. But if we don't pay attention to the mind-body connection, then we're going to miss out on a lot of things
Absolutely.
that can bring that holistic, integrative healing, So thank you so
I
much
agree.
for championing this. I love this.
Yeah.
Um, speaking of clinical advances, there are so many exciting advances happening in
Mhm.
ovarian cancer. So if you were to, I know that, like at SGO this year or some other events, there are lots of new data and lots of new reports published and studies that came out. So if you had to summarize the top three things you are most excited about, what would you share with our overcomers?
Yeah, so I think, we're just in the infancy, but cellular therapies I think are really exciting because a lot of them target the immune system because we know that the ovarian cancer is sort of immune dependent. We've seen that for a long time with T cells and sort of how they integrate into helping us overcome ovarian cancer, but we haven't been really great in terms of how do we target that to make our immune system rise to that occasion. So now there's cellular therapies to do that. So I think that's very exciting. I think, we also are doing some type of virus work by putting a vaccinia virus into the peritoneal cavity, and that's part of a clinical trial called Olivec. And it's, going back to sort of what ovarian cancer has initially been treated with, which is intraperitoneal, right? Bathing that sort of, area of the body, which has cancer in it. And that has some encouraging results based on a phase 2 and now it's a phase 3, because that's in platinum resistant ovarian cancer, which, is always so much harder to treat. And that's an unmet need because you had asked, what are some of the unmet needs? And I'm sure you've heard that over and over again on your podcast. So that's exciting. And then we also are finally having WEE1 inhibitor that can be exciting to help as stopping the cell cycle. And there's definitely been other companies that have tried to have WEE1 inhibitors, but they've been a little too toxic for patients. And so now we finally found one that we think is something that patients can tolerate. So this is also going through phase 2 and hopefully a phase 3 trial. And then, I think some of the other unmet needs is also maintenance therapies for those patients who don't have a BRCA or an HRD signature. So, we're trying to figure out, we haven't had some successes yet, but that doesn't mean we're not trying to find other mechanisms. So I do think there's lots of encouraging drug development. I think we're also going to start looking at HIPEC, more in a neoadjuvant setting for surgery, because there's conflicting data depending where you are in the world as to whether you should get HIPEC or not. There's like early adopters. Lots of Europeans are giving it, some centers in the US. India loves to give a lot of HIPEC. So it's, just trying to look at it a little bit more in a streamlined clinical trial, because the Norwegian data that we have to date was done over, 15 plus years. So there's some question of, what was given as standard of care at that time, was that really would change sort of the outcome. So I think there's a lot of great things being done, and we just need to stay tuned, which is always hard.
True. So you talked about the virus. I mean, I want to know a little more about that. So, is it like, what do you do? How do you get that virus into the patient? Is that an injection or how does that work?
Yeah. So what it is it's really for patients who have platinum-resistant disease, ovarian cancer, and they could have had up to 3 to 4 lines prior, which is nice because, a lot of the other trials are limited to after 1 or 2 recurrences. And it's either surgically implanted laparoscopically by a GYN oncologist, or it is done by sometimes our interventional radiologists, and they put what we call like a peritoneal dialysis catheter, so a tube, and it stays in for a short amount of time, meaning like less than a week. And it's actually infused into the abdomen, and you still get chemotherapy. You go back on carboplatin. an agent along with this vaccine or vaccinia, excuse me, virus. And the vaccinia virus is supposed to help cause more of an immunoinflammatory process to allow the chemotherapy to work better. Because all these patients are like, I'm getting platinum again, but it's because you're using something to synergize. And that is being done by a company called Olivec. I'm one of the national PIs for it. But it's exciting because, sometimes, as I said, you have to put different combinations of drugs together. And so you're using chemotherapy, which is a standard, but you're also using something that's novel. And so we'll wait to see. They had very encouraging results with a non-randomized phase 2, where they saw overall response rates of about 54%, which is not usually heard of. So that's why we're trying to do a phase 3, because sometimes, until you're randomized and you have a control group, you never know what might show up in that. So it's actively accruing. And so it's just saying that there's lots of different ways that all of us are still trying to attack cancer. And so there's lots of excitement about different modalities to help.
And you're sharing so many important points that I have to keep going back to what you said. So the WEE1 inhibitors that you spoke about,
Mhm.
what do you do with that?
Yeah, so WEE1 inhibitor is an oral drug that's given, and so it's one that's given sometimes in combination with chemotherapy, and so it's not because some patients might not want to take have something implanted in them temporarily even, so that's why I think it's another great way for patients to get the drugs and to go from there.
And finally, on the HIPEC, because I know what you said, there are two schools of thought on HIPEC. I mean,
Yeah.
some believe in it, some really don't believe so much in it. So, from your standpoint, who do you think are the best candidates for HIPEC at this?
Yeah. So I think it's really like looking on a clinical trial and trying to, figure that out. But I do think, potentially the data that I've seen the most encouragement is probably patients who have been after neoadjuvant chemotherapy and then they get it during surgery. But, we're really trying to figure it out because some people are like, is it really the heat? Is it really the drugs that you're giving? Is it the combination? And so I think that's what we're trying to get after. And seeing how they do, because we also want to know, are they able to be reoperated on? Because some rare patients might need a secondary debulking or, a third debulking sometimes. And what does that cause in terms of scar tissue? If you talk to some of the people who are even more senior than myself, they would talk to you about giving radioactive phosphorus in the abdomen given in the 80s and 90s. And they're like, if you ever had to go back into a patient after that, they would be like, it's so much scar tissue, very hard, causes complications. And so I think there's lots of things to learn from this, and hopefully we'll get better and sort of figure out who are those patients. Are they the patients who are, not HRD positive, not BRCA, maybe they would benefit more. So I think we're trying to also put it in a more molecular understanding of which patients would benefit or not, as opposed to just the neoadjuvant patient who needs it. So I think it's going to be very interesting. When I went to a conference in India several years ago, they were even talking about PIPEC, pressurized intraperitoneal chemotherapy that doesn't need heat, which is more of a French way of giving, therapy. So there's lots of different ways. And I think that's also the nice thing about being in oncology. You can learn from your colleagues from all over the world, because I never heard of PIPEC, to be honest, until I went to a conference abroad, because there's no one in the US that I really know who's doing it for ovarian cancer yet. So I think there's so much that we all have such a great exchange when we do a global approach to anything.
Absolutely. And so you spoke a little bit about the unmet needs in ovarian cancer. I'm going to go back to that question because I have it
Sure.
as one of my key questions to ask. From
Yeah.
In your opinion and from your perspective, what are there's lots of advances, but there are also unmet needs yet, right?
Yeah.
And that we have not reached yet. So what are some of the top unmet needs in ovarian cancer, and how are they being addressed right now? And where does the patient voice fit in this picture? Tell us about that.
Yeah. So first, I'll start with the patient voice, because I think the best thing that's happening in clinical trials, as well as just cancer care, is the empowerment of the patient voice. So now all clinical trials need to have pretty much a patient advocate to review the trials, because, so many times, like 10 years ago, you'd review a trial and the patients would be like, I would never have designed it that way. It just doesn't fit, is just too burdensome, or how can we think of innovative ways? And I think the one thing that has also come out of COVID that's been helpful is just a way of sort of decentralizing some things in medicine, right? That you're able to get some of your labs done maybe closer to home, or, telehealth has become an option for certain things. So I'm hopeful that we don't go backwards and say that we're not allowed to do those things, but we'll see. So I do think some advancements have been made, but the patient voice has really been the best, because they're the ones who can advocate and have such an equal footing at the table, which I think it was not always appreciated. So I think that's been a huge help, because they recognize things that I think sometimes as physicians we overlook or just don't even pay attention to. And that has been super helpful. In terms of unmet needs that you asked, I think it's, maintenance therapies. Everyone wants the cancer never to come back. So how do we have better options? And I can't say I know of a million trials yet trying to figure out the non-HRD, cohort or non-BRCA, because, if you're not in that cohort, we almost have a stressor the other way now, right? Like the sadness that you don't have that molecular signature. We know that's a pretty high number. So there's lots of different molecules trying to be developed, and also what's acceptable, because, when we're maintaining a response, we also have to have a little bit more of an eye of, it can't be burdensome, especially if it's not an oral agent, that you're not coming weekly for something when you're saying you're maintaining a response. So I think all these things sort of play a role. Additionally, I think what's also important for this is, trying to figure out things for platinum resistance. Also, do we have better ways to monitor patients for recurrence? There's a lot of talk about ctDNA, and is that ready yet for prime time, as opposed to just your CA-125? And still, it's too early to say, but are we going to have better ways to detect recurrences? So maybe we can, do something sooner about that. So I do think there's a lot of unmet needs. So whoever is on this call, and maybe just inspire a future generation, there's a lot of work to be had. So I do think we're excited, but we also have a lot to do still.
Makes sense. Thank you. So, I'm going to talk to you about the progression, two terms that we would hear and read about all the time: the progression-free survival and the overall survival, right? Especially in trials. So, as I understand, there are two key metrics in any trial design, right? So tell us why they're important and at what threshold they're considered significant and why.
Yeah. So progression-free survival is really defined as, if you're in a clinical trial or whenever you start treatment, till the time, hopefully the disease goes away. And then, sadly, if you recur, it's that duration of when you started treatment till the first recurrence. And it's important because we had to have some metric to understand how do you counsel patients when you get diagnosed with stage 1 versus stage 2 or 3 or 4. And that's how we sort of give, some statistics for that. And then overall survival means how long have you lived with the disease until, unfortunately, you've passed away. So from time of diagnosis till, you might pass from this. And so that's why we say it's like a disease-specific overall survival, because somebody may sadly pass away because of motor vehicle accident or something else, and that's not really related to the drug, or to the cancer. So we do sort of define that. And the reason we have these metrics is also to say, are we improving patients' survival by adding these different regimens? Because just like anything, we could also be harming patients if we're decreasing their survival that we know we could get on average with standard of care. And, so far in clinical trials, it's always been defined by a statistical value of how much of an improvement. And so we usually would say at least 30%, but lately we've been a little spoiled with like adding a PARP inhibitor, we decrease those down to 60% improvements, right? We have patients who hopefully we even think are cured now that we've seen survival curves lasting now 7 years, and patients haven't recurred. So trying to understand that. So, I think it's always important, especially in the upfront when we have these long, but then when we get the recurrences, we don't see those huge improvements. If you look at statistically significant data for like mirvetuximab that came out for platinum-resistant disease, if you really look at the progression-free survival benefit, it's about 2.8 months. Which is statistically significant and yes, a big deal. But, if I talk to a patient and I say it's about 90 days, they're not thrilled, right? Like they want to make it to 6 months, a year, years, right? So, and those are averages. So I always try not to dwell on the statistics, but more on like the biology and what it is, because for you, it can be incrementally better. Because if we know from stats, remember there's the bell curves, there's always those super responders or people who do even well. And the definition when you recur in my mind is also even a stable disease. There's lots of women who have active lives, who have stable disease and take their treatment, but are doing more things than a lot of us. So, what is your quality of life as well as giving you quantity? So it changes a little bit depending where you are on that journey also of cancer.
And thank you for mentioning this, because I was just thinking, I was going to ask you about this exact thing that you said, that in some of the clinical trials that I read, I see that, the progression-free survival is 2.8%, 8 months more or 3 months more, or, but there is that equation of cost, financial cost, plus the lifestyle cost of this, plus
Right.
of life, plus everything else. So does that 2 or 3 months that this gives you, is that something that's significant to the patient? Maybe it is statistically significant for the science, but is it significant for the patient? And you already answered that question for me, so thank you, because I was like, this is something that I feel that needs to be addressed a little more, in sitting down with patients and asking them how they feel about that, because some of these clinical trials can come with a lot of toxicity even, right? So is that 90 days or, like 120 days worth
Really
when it comes to,
yeah.
I mean, I shouldn't use the word worth, but is it like, if you are bogged down by side effects that you cannot get up from the bed, or it's financially taxing, then how do you kind of manage all of that and say yes to the proposal, right?
Yeah. And that's where it's the art of oncology, and that's what's so special about being a GYN oncologist, because we are your surgeon. We're the ones who take you through your disease journey. So I feel like you get those relationships that you also get to know, because when you see a patient in your office, I tell everyone, like, I need to know exactly what you're saying. Like, are you stuck in bed all the other days and you just managed to put yourself together and come to my office? Because if that's what you're doing, then this may not be really worth it. We have to try something else, or, at that point, is it worth doing, symptom management? Because I've also been stunned at how well sometimes patients do when they're off of a treatment. I thought they would not do as well. They've lived longer than probably I could imagine for sure, but a better quality too of life. So, but these are hard discussions. There's lots of, culturally based, issues that you sometimes may or may not know, family based issues. There might be a new baby coming, a grandchild, or some milestone that we must make it to in their mind. And so it's really challenging. And I think that's where I also sort of look at my stress work about it. Because, there's some people can will themselves to live too, no matter what. And there are others who just sort of crumble up and get crushed. And you're just like, what is that difference? Because it's very interesting how we all react and what we sort of have our purpose, right? Our purpose or meaning. And in oncology, there's no way to define that. I mean, it's only defined as by months or weeks of life, but there's much more to it, as you said, with the mind-body connection, which we need to continue to do better at.
Absolutely. And it's a patient to patient, person to person, right? I mean, there's no like standard to this. So, I mean, how we react to situations like this. So, we talked about a lot of like we talked about the unmet needs, but in terms of seeking timely treatment of ovarian cancer, what do you see as the greatest barriers today that exist, and how we may overcome the disparities that exist today between, big academic centers and the community setting hospitals,
Right.
when it comes to ensuring equity in care practices?
So I do, at least I see this in my own area, and I do think COVID has put us backwards in that, because I do feel like some of those great connections we had, I sort of look at academics almost as like the safety net, right? Like, most patients, like we discussed, are treated in their community. And the one sort of biggest thing that we have that you're just now mentioning and came to my mind is we don't have a good test, right? So we find these women very late, and we haven't made true strides in improving, right? We can definitely do prevention if we know you have a genetic predisposition, but we don't have like a test for all women. And, the prevalence is low of ovarian cancer. So we haven't made improvements there, even though people have tried by looking at swabs in the vagina and looking at the microenvironments or differences we can see. And hopefully doing these self-injectomies on women will help down the road decrease the incidence. But in order to get equity, I think, if you or your loved one are diagnosed, is really trying to make sure that you talk with your medical oncologist to try to figure out how many do you treat? The common question you ask anyone if they're doing something for you, because if you are being treated at a low volume center, there's data that you don't do as well as if you're at a high volume center. So that doesn't mean that you can't receive some of your treatments in the community, but should you really seek out that second opinion or go and make that extra effort to go to another center to just get that expertise? The sad thing is, a lot of GYN oncologists or academic centers are in bigger cities. So we do a disservice to our rural communities, or even some of our more sparser populated states like Montana, or places which are beautiful, but they don't necessarily have as much access. So I don't have an answer of how to do it. I would hope that like maybe telehealth can help us overcome some of this, because then patients don't have to travel, and at least we can get records and we can have a discussion on a Zoom or a Teams meeting or something that can help get them that access. But there's a lot of work still to do with just generalized, access to GYN oncologists, because we're also a small subspecialty, and having a surgeon do your surgery is not as good as a GYN oncologist. A surgical oncologist doing it is not as good, because we have lots of data to show that. So trying to advocate for women. And I think that's where it's great that we have a lot of our survivors who go and do like teaching to the medical students. So even if they become family practice or internal medicine, that maybe they remember that patient, telling them their journey and story. It means so much more than just reading it in a textbook, and it doesn't have that personalized content. So I do think our survivors and our ovarian cancer patients are our biggest benefit to educate, actually more than the physicians sometimes.
I agree with you 100%. So switching gears just a little bit, we are talking primarily about clinical trials, but I also know that you are involved in some great work on low-grade serous ovarian cancer. So what would you do? What does progress look like when it comes to low-grade serous ovarian cancer? And what would you like to share with our overcomers in terms of new trials or novel therapies coming in or are in the near horizon?
Yeah, so I think first of all, low-grade ovarian cancer is an entity that pathologically was just sort of, recognized by its own entity in 2006 with the great work of Dr. Gershenson and MD Anderson and the pathologists there, because otherwise, if you look before that, we just lumped everything as ovarian cancer. So one, getting expert pathology is a key, because, as I mentioned, there's lots of patients who get treated at lower volume centers. So then they just say ovarian cancer, but you don't know, is it low or high grade? Because the majority are high grade. So about only 3 to 5% of ovarian cancers are really low grade. So it's a smaller subset, but it tends to affect women when they're younger. And then also when they are older, and there's different sort of molecular targets for it. So, there's actually a great trial ongoing right now to say, do these patients even need chemotherapy? Because we're not convinced that chemotherapy helps them. And maybe some of our hormonal agents would be better, such as letrozole. So there's a trial looking at that. And it's a phase 3 trial. So hopefully we'll get an answer and maybe save women and de-escalate the need for chemotherapy. But one of the things is these patients live longer with low grade because it tends to be slower growing. So they do have recurrences. And so we're trying to figure out better treatments. And we had improvements with MEK inhibitors, such as like trametinib and others. But, really it still had a overall lower success rate. So now we're looking at the combination of a MEK inhibitor along with a FAK inhibitor. So there's a trial called RAMP 201, which just completed. It's a phase 2 trial looking at these two agents together. And then what they ended up finding is that their overall response rate was close to 54%, so quite high. And so now it's being done in a larger phase 3 trial, which is global, which will be great because, as we mentioned earlier, we want to get as many different ethnicities and, geographic areas to get involved so that we can really say this is a treatment for all women, not just a Caucasian, European, more bent population. So it's really encouraging to see that. And, before that was considered an orphan cancer because it's a rare tumor in a rarer subset. So it's nice to see that companies are really excited to do, investments in this type of great work that's needed and necessary. So I'm really excited by that because before when we talked about rare tumors, you felt even more like you're left out by yourself. But now there's definitely more options. And that's because of molecular characterizations and better biology to understand how to target these cancers.
Just a curious question in this on this. So for this community, like you said, I mean, I have also talked to patients and reading just journals and articles. It seems like there's so little available for these patients. So when a clinical trial comes into the picture for this particular segment, do you feel that the adoption rate is higher for these patients versus the general not general ovarian, but the bigger pool of ovarian cancer, or is it the same? What do you?
I do think it is higher because they're looking for trials. I think the difference, which I also realize because I do a lot of like patient education, is that there are not resources really dedicated for low grade. So we've started to develop them because, we do talk about, as I know you do in your podcast and things about like fertility and sexuality and all of that. But I do think these women feel it a little differently because they are younger. It's almost like how we see in a breast cancer population, the younger, onset have different sort of needs than sometimes the patients who are perimenopausal or postmenopausal. And so we're trying to develop, education geared for those women so they also feel empowered, and also trying to help them connect because they sometimes join these larger groups like the Ovarian Cancer National Alliance or Overcome, and they're like, well, we're such a small percent though, of it. So we're trying to also gather resources to help them feel empowered because a lot of, I feel like, great information is disseminated through these type of groups, right? So getting the word out like we are today on this podcast, that even there's somebody who's like, oh, I think I heard there was a trial, that they might go and Google it or try to look for one. Because sometimes they don't think they're included because they're usually excluded from all the high grade ovarian cancer trials. So they sometimes get dismayed. So it's nice to see that we have some options for them too.
That's wonderful. So great discussion, Dr. Thaker. So just a quick question on about you. So what keeps Dr. Thaker hopeful and motivated about a world without ovarian cancer?
I think what keeps me very hopeful is just the science and how I can even say in my career, we've made huge impacts, with the maintenance therapies and just like having such great colleagues who are all inquisitive, who are trying to eradicate this disease. I've many a time on our Siteman Cancer Center, I have a quote saying, I'd love to be out of a job.
Right, exactly.
So,
I agree with that. And so I've asked you a lot of questions. What have I missed asking that you would like to share with us today?
I think the main thing is, what for your like audience is just to know that there's lots of options. And if you're only presenting with maybe one option, just ask your provider to tell you what other options might be there, or ask them this question of what else do you think I should ask? Because, sometimes providers also may have, not be thinking that there's something else available for you, or trying to even get a second opinion. I honestly think that's great. I want every patient not to have a regret. I know some other providers might take that as a personal, oh my gosh, they don't trust me. But I'm like, this is your life, and you need to, at the end of the day, feel comfortable that you made the right decisions for you, your family, or whoever's important in your life, and not have a regret. Because, the worst thing for any of us in life is to have a regret. So just be an advocate for yourself, because sometimes I know it might be uncomfortable for some patients to do that. But know that, a good doctor is going to encourage you to get the best information, because not all of us know everything. I'm always humbled by sometimes my colleagues who are like, did you think of that? And I'm like, no, I didn't. But that's why we have multidisciplinary tumor boards and having sometimes multiple minds talking about the same patient, so we get the best, hopefully, outcome and answer for that patient.
Thank you for that candidness. And I would just add to that is in working with our patients in the community settings, we also know, and you raised that point earlier in the discussion, is that oftentimes these patients are not talked about clinical trials, so by the providers. So when you said ask more questions, I think also having that question as a standard question to ask your provider is, what clinical trials are available to me? Maybe not at this center, but somewhere else that I could potentially look into. I think that's a very important question as well, because not all providers are, offering those options
Right.
to the patients, themselves.
Yes, you're absolutely correct. And as I said, a lot of patients are treated in a community where they just may not have that option, because, if I have to be brutally honest, when, hospitals have to make decisions, they make decisions based on what are the larger volume of patients they see. So they open trials for colon cancer or for breast or lung, and they sometimes put GYN a little bit on the lower end, because resources are tight, and they are like, well, we only see so many, so it's not going to be as helpful for our trials organization, because trials are a labor of love. Like I said, you have the face of the physician, but there are literally 12 other people behind me trying to help you get through that trial. So it's a big investment for any organization to help it be successful, because you said what makes it successful is all the support that we need to help these patients.
Love your candidness. Thank you, Dr. Thaker. So just in closing, what message of overcoming would you like to share with our audience listening today?
Well, I think my main message is that there's lots of hope, and that the world is small, because, I love to hear that you have such a great global audience, because sometimes I feel like I've learned so much, from the global experience, and that the ability to attain, trials and to novel drugs is stupendous. Because it's funny to me that I've had actually some patients in India get the drugs before my patients here in the US, because they have a means. And they're like, yes, we can get that because we know somebody, maybe in the Middle East, or we know someone in Europe, and we can get it. And I'm like, wow, I need to know your contacts, So I think it's just being creative and understanding that we all need to work together for a cancer-free world.
Such a powerful message. Thank you so much, Dr. Thaker, for the discussion today. We learned so much from you, as we always do from all our episode guests. So thank you so much for your time and for the insightful discussion. And overcomers, hope this was beneficial for you. I know, as I always say, for all these episodes, we end up learning so much from these experts that join us to give their, their time and the information that they share with us so freely. So please share this video far and wide with anyone who may benefit from all the pearls of wisdom and the insights that Dr. Thaker mentioned or shared with us today. And we will be back with the next episode of Connect Over Coffee very soon. Until then, you keep inspiring and keep overcoming. Thank you and bye.